So it is very important that we need to differentiate between Sga and Fgr. So remember, Sga are the babies which fall between 3rd to 10th centile. Both are below 10th centile, but Sga are between 3rd to 10th centile with normal Doppler studies. I repeat, the Sga babies are the babies which falls between 3rd to 10th centile with normal Doppler study, whereas the Fgr babies are the babies which falls below 3rd centile even though the Doppler is normal. And also the Fgr babies are the babies which fall below 10 percentile with abnormal Doppler changes. So these definitions we need to remember. Sga babies are the babies which falls between 3rd to 10th centile with normal Doppler studies. Any baby weight which falls below 3rd centile even though there is a normal Doppler, and any babies which fall below 10th centile with abnormal Doppler change are called as Fgr babies. So the normal for Doppler thing I have already explained. We have to take only maternal arteries like both the uterine arteries left and right, and for fetal we have to take umbilical, middle cerebral and the ductus venosus artery. So how we will detect the Fgr? Whenever we are suspecting Sga or Fgr, what we need to do, one single reading is not important. So suppose I have seen one patient and I suspected Sgr, so I will ask for the previous growth report. How was the growth in the anomaly scan? How was the growth in the NT scan or any prior scan if the baby has done? So serial monitoring is important. You cannot diagnose Fgr suddenly when the patient has not done any scan and has landed up at 28 weeks. You cannot say that this is a Fgr baby. You have to call them back again after 2 weeks to reassess whether you are not missing any delay in conception or something like that. So we cannot, in single visit, we cannot predict that this is an Fgr baby. Serial monitoring is must. 2 to 3 weekly repeat measurement is always a requirement. What are the risk factors? There are many risk factors. Most common fetal risk factors are chromosomal anomalies, genetic syndromes, and any congenital anomalies that may lead to fetal growth restriction. Coming to the placental part, mosaicism of the placenta, any uterine anomalies, and velamentous insertion. Velamentous insertion of placenta is a common cause of fetal growth restriction and not the normal insertion. The most common cause of maternal factor which lead to Fgr is idiopathic. You remember this most common cause of maternal cause of Fgr is idiopathic and it is not the chronic disease. Yes, it is associated with chronic diseases and abnormal implantation, but the most common is idiopathic. External factors like smoking, infection, and psychosocial factor. What is more important, what is priceless is you can always measure uterine circulation in first trimester as well as in the second trimester. What it will help? If you do the uterine circulation, that is the maternal uterine arteries both left and right, you can pick up high risk women. Some patients are coming to me at 13 weeks for first trimester scan. When I do the uterine circulation, I find there is high resistance flow in the uterine arteries. I start those patients on aspirin. Because the dose of aspirin, as you know, it has long been discussed, the tablet aspirin, 150 milligram, one tablet at bedtime, it works like anything. So we prescribe and it works. We have to supplement aspirin before 16 weeks. So it is the best time to assess for the uterine artery Doppler and substitute the patient with aspirin 150 milligram. So you have moderately predicted the FGR fetuses, and these fetuses are doing very good in their life. More than 80% prevention of preterm preeclampsia. So you have prevented so many FGR babies by doing a uterine circulation PI at early trimester, that is 11 to 13 weeks, 6 days scan. So that is very important. This we can take it as very positive thing, that even though we cannot do anything, we can just without taking much of the time, we can do uterine artery and we can predict FGR. Now there is in FGR, there are again the two things. I've told that since there is a two things like Sga and Fgr. Sga, we know that any baby which has the growth of 3 to 10 percentile without the Doppler involvement, because those fetuses are as Sga and we follow them every 2 weekly. And FGR fetuses are anyone which is falls below the third centile or below 10 centile with Doppler involvement. But these FGR fetuses, they are of two types, early FGR and the late FGR. You will be astonished to know that most of the stillbirth term IUDs are the late FGR babies which are missed by the scan, because late FGR babies are very difficult to diagnose but very easy to treat. So what we need to know, that we need to do routine Doppler scan for all the patients after 28 weeks at least once, because those are the Dopplers which will tell you about late FGR. Early FGR you will know early. It is very easy to diagnose because all the parameters will fall below 10 centile. But in late FGR, the baby will be either low for gestational age or will be appropriate for gestational age. So very difficult to diagnose as FGR. These babies are AGA babies, that is appropriate for gestational age. The only thing you can diagnose the late FGR babies are doing by doing Doppler. When you see that there is altered CPR, that is cerebroplacental ratio. Whenever there is altered CPR, you will know that these are the babies which are late FGR, and these are the babies which are going to land up in stillbirth. And we don't get the answer. Patient is asking, why 2 weeks before you have seen my scan, why my baby died? So you have to be very cautious in doing the ultrasound as well as for the Doppler. So this 32 weeks is not a particular week. Both the early FGR and late FGR can develop at any period of gestation. But generally, these early FGR babies are less than 32 weeks, and late FGR happens after 32 weeks of gestation, but it is not fixed. 32 weeks is not fixed. So as I have told, early FGR very easy to diagnose because the parameters are LGA, SGA, and they are very difficult to treat. And these late FGR babies are very difficult to diagnose as they are appropriate for gestational age, and they are the one which goes for maximum complication. Because these early FGR babies, they are very tuned to hypoxia. They can tolerate hypoxia. But these AGA babies, those late FGR babies, they cannot tolerate hypoxia and they land up in stillbirth and IUDs. So we have to be very cautious for the late FGR fetuses. So we have to know the difference. So when to deliver these early FGR fetuses? What is the problem in early FGR? From the beginning, they are low growth. So they have low growth potential associated with Doppler. So what it can lead? Please mute yourself.
डिस्टर्ब होती ठीक है सुजाता राउत म्यूट करो डिस्टर्बेंस होची प्लीज पोस्ट प्लीज म्यूट प्रीति
With increasing gestational age, there is decrease in neurodisability. What we are worried for? Why we are worried for the fetuses? Because of death, perinatal death, perinatal mortality and the morbidity and the neurodisability. These two things we are very much worried for. So we have to balance between neurodisability and the perinatal mortality as well as morbidity to deliver the fetus. So that is very important when to intervene in early FGR. So when to intervene, this is the truffle group which has given this finding and its implication in management. Whenever the fetus is less than 32 weeks, then based on ductus venosus, when the in the early FGR group, when the fetus is less than 32 weeks, you have to monitor umbilical, MCA as well as ductus. Till the time ductus is normal, you can continue the pregnancy. When the ductus is there is absent A wave or reversal of A wave in the ductus venosus, that is the point where we have to deliver the fetus. So there is, because we find that there is low risk of neuro impairment if delivery is based on the absent or reversed A wave. Once the baby has crossed 30 to 32 weeks, after that role of umbilical artery Doppler comes in play. At 30 to 30 weeks, 32 weeks, reverse umbilical artery, if you see, you have to deliver. Between 32 to 34 weeks, if there is absent diastolic flow, you have to deliver. And between 34 to 36 weeks, if there is increased pulsatility increase, anything which is more than 90 to 95%, we need to deliver the thing. So it is very important how you have to deliver in early FGR fetuses. So in early FGR fetuses, you need to individualize, you have to differentiate it from Sga, and then you have to individualize. Every second weekly you need to monitor those fetus, consider complications during pregnancy, clinical examination is always necessary, and Doppler of the umbilical artery plus ductus venosus is very important. In late FGR, what is utmost important is the cerebroplacental ratio, because as I have already told you that these fetuses are AGA fetuses. So CPR is the only thing which comes in mind to monitor, to catch these late FGR fetuses, and the delivery, as soon as you diagnose late FGR fetuses, you have to induce those babies and you have to deliver. The thing is very simple, very difficult to diagnose, very easy to treat. That is late FGR. But early FGR is very easy to diagnose, but very difficult to treat. So this is to sum up this between early and late responses of the placental insufficiency. You see, this is early onset FGR, and this is the normal umbilical artery. This is the elevated Doppler indexes, that is CPR, and there is absent or reversed end diastolic flow velocity in the umbilical artery, and there is a brain sparing effect in the MCA, and there is reversal of flow in the ductus venosus flow. So these are the pattern changes that happen in early onset IUGR. So you have lot of time and you need to monitor those babies very frequently, and then you can plan a delivery. As I have already explained that how to do the management based on truffle study. In late onset IUGR, the entire process happens within 2 to 3 weeks, in such a short span of time that you need to be very cautious to diagnose late FGR, and you have to immediately induce these babies, because there is normal umbilical artery and there is elevated Doppler indexes. That is the only sole point That's altered CPR for late onset FGR. There is elevated Doppler indexes and there happens the brain sparing and the immediately baby land up in trouble. So we need to know that late onset FGR babies are always AGA baby. They lead into stillbirth and the high perinatal mortality rate. We need to catch these babies and separate them from early FGR babies. So now I have told about what is SGA, what is early FGR, what is late FGR. That is the growth less than 10 centile. And now I will go to, I don't stop. Now I will go to growth more than 90 percentile. So any growth which is more than 90 percentile, we call this baby as LGA, that is large for gestational age, or macrosomic babies. So these babies, as per Indian quantification, we take any birth weight at term more than 4 kg, or if it is gestational age dependent, at any period of gestation, if the estimated fetal weight falls beyond 90th centile, then we call it as LGA or macrosomic baby. Whereas in Western countries, it is birth weight more than 4.5 kg or gestational age dependent period of gestation related to more than 97 percentile is known as macrosomia baby. So what are the common risk factors of macrosomia? This is maternal diabetes, gestational diabetes or maternal obesity. As we know that India is the diabetic capital of the world, we are getting such babies very frequently in our day-to-day practices. So we need to have a great look on these mothers to prevent them from macrosomia, as you all know the complication. The three most common syndromes which are associated with macrosomia is Beckwith-Wiedemann syndrome, Simpson-Gulabi-Baimel syndrome and the Soto syndrome. These are the three syndromes which are commonly associated with macrosomia. I repeat, Beckwith-Wiedemann syndrome, Simpson-Gulabi-Baimel syndrome and the Soto syndrome. Then what are the risk factors? What are the risks that is associated with mother as well as for the infant? So risks for the mothers are they land up in emergency cesarean, they land up with more instrumental delivery, shoulder dystocia, trauma to the birth canal, bladder injury, sphincter injury, perineal injury. All these are risks for the mother. Risks for infant, there is mortality, morbidity, there is brachial plexus injury, facial nerve injury, various fracture, humerus, clavicle, all fracture, and there is birth asphyxia. So, to know these risk factors, we need to prevent them by early diagnosing the thing. So, prevention is always better than cure. So, we need to catch early to prevent them from these injuries. What are the ultrasound marker? We have to assess again the risk factor, as I have told, that we need to see whether there is obesity or there is associated diabetes. Either it is pre-gestational or the gestational diabetes. Both are at risk of delivering macrosomic baby. And we need to find out any syndromes, the three most common syndromes, if there is any association with the baby. Ultrasound for fetal size at 30 to 34 weeks has to be done. Repeat ultrasound to see whether the growth is always maintained in more than 90 centile or not. If it is more than 90 centile, then we need to repeat such babies again at 38 to 39 weeks. And if we find that estimated fetal weight is very much high, we need to transfer this patient to a good tertiary care center for better delivery. Coming to the growth in twins. growth in twins is very important. We need to monitor the first time of the growth of the baby during the early first trimester scan, that is between 11 to 13 weeks 6 days scan. And thereafter, if what we have to know is the chorionicity, because chorionicity is very important. You will have to monitor how frequently you are going to monitor the baby.
Please, no
Depends on the
disturbance.
chorionicity.
Please, no disturbance. Host, host, please mute others.
So for twins, we have to know the chorionicity in early trimester. As we all know, till 14 weeks, almost 15 to 20% of the babies, they lost their chorionicity. So it is very important to ascertain the chorionicity before 14 weeks. And based on that, we need to call the patient. How frequently we need to call the patient is based on the chorionicity of the placenta. So that is very important. So we give lot of emphasis whenever you are seeing a twin. Please don't write a twin pregnancy. Twin pregnancy is not a diagnosis. You need to write what chorionicity and what amnionicity is there. You have to write DCDA twin, MCDA twin, Momo twin. So we will know how frequently we need to see those babies. So if there is dichorionic twin and there is no discrepancy between the two fetuses, between the CRL of the two fetuses, then we need to follow up these DCDA twin at 20 weeks, directly at 20 weeks for anomaly scan, and thereafter we need to follow up every 4 weekly till the baby delivers, because the complications are less in dichorionic diamniotic twin. If there is a size difference in or in the CRL difference more than 2 weeks in the first trimester itself, then we need to see those babies at 16 weeks, then at 20 weeks, and thereafter every 2 weekly. Whereas in monochorionic twin, from 14 weeks onwards, every 2 weekly we need to see the fetuses, because these are the fetuses which are going into complications very frequently. Selective FGR, then twin anemia polycythemia syndrome, that is TAPS, TOPS, twin oligohydramnios polyhydramnios syndrome, and the TTTS, twin to twin transfusion syndrome, that stage 1 to 5. So these are the babies which are going into more complication. So whenever there is a sharing placenta or whenever there is monochorionic twin, these fetuses need to monitor very frequently, every 2 weekly, because immediately at 18 weeks I have seen a twin, 20 weeks they will come with as selective FGR. So you will never know at what time they will present at work. I have seen so many babies which are doing good at 20 weeks, 22, 24 weeks, they will land up in TTTS syndrome. So these babies need your constant monitoring, and yes, you have to do it Doppler also for monochorionic twin from 20 weeks onwards. So that is very important for twins. If it is dichorionic diamniotic twin, you have to do NT scan at 11 to 13 weeks, ascertain the chorionicity and amnionicity at 11 to 13 weeks 6 days, and then you need to monitor the baby from anomaly scan at 4-week interval. Whereas in monochorionic twin, after 14 weeks, you have to monitor these fetuses at 2 weeks interval, because these are the babies which land up in more complications. So to summarize, use BPD, SC, AC and FL to assess the estimated fetal weight. Leave 2 weeks between the scans. Beware of the cause of impaired and increased growth. Assess growth pattern to monitor risk of associated anomalies. Start, onset and frequency of the growth assessment. It depends on chorionicity. Assess amniotic fluid and fetal well-being every time during scan. Thank you and have a wonderful day.
Thank you very much, Preeti. Now you can unmute yourself and ask Preeti Madam any questions. Right at the outset, before you are ready, I am asking one question. Is yeah, Doppler studies of uterine artery have any significance with fetal growth disorder? I mean later on. We know that in 30, less than 16 weeks, if we find the pulsatility index high, then it tells us that we have to give aspirin. But later on in second trimester, late second trimester, as well as in third trimester, should we do the uterine artery Doppler, and has it any implication on the fetal growth, and as well as does it indicate any decision to terminate this pregnancy? Hope you heard my question, Preeti. Yes. No, we can't. Unmute yourself. Unmute.
Sorry, madam. So in first trimester, we know that we are going to give aspirin only if that is higher. In second trimester, usually the placentation is completed by 22 to 24 weeks. Okay, so by that time, if your first trimester uterine resistance is high, and if you find that in second trimester it has come to normal, that means these are the fetuses which will not grow to FGR, which will not commonly go to FGR. So at least you will follow up those babies in the second trimester scan. And if there is no uterine done for the babies, then you have to do uterine to know the pathology. Where is the pathology? Is this the uterine which is the pathological, or it is the placental impairment which is causing less flow in the umbilical artery? So to differentiate between these two pathology, you have to know the uterine arteries in the later gestation.
Just supposing you have started on aspirin with high pulsatility index before 16 weeks, and then if it becomes normal in the second trimester, say 20 weeks during TIFA, should we stop the aspirin or should we continue?
No, madam. Once aspirin is started, it has to be stopped only at 34 to 36 weeks.
I hope everybody has noted this very important question, that aspirin once started has to continue till 34 to 36 weeks. And you have to follow the growth pattern also of this baby. So thank you for this question. Another, yes, others you can ask. It's a very important subject, and please unmute yourself and ask questions, or put your questions in the chat box. Put your questions in the chat box or unmute yourself and ask questions.
Madam, please tell me the umbilical Ductus venosus Doppler, madam. Doppler of the Ductus venosus.
Ductus venosus, yes. Ductus venosus Doppler and its implications.
How can we know that it is abnormal or?
But those things, I think, Jyotsna madam will take in the next class. Anyway, I will tell. You have to keep the spectral waveform on the ductus venosus. I hope you know how to take ductus.
Yes.
Then after getting those waveforms, they are usually amp pattern waveforms are coming.
Yes.
So these amp pattern waveform should not come to the baseline. If it touches the baseline, that means there is absent A wave. This amp pattern should go like this, so that it should not touch the baseline. If it is touching the baseline, that is absent A wave, and if it is going down, that is reversal of A wave. So these two are very important thing in identifying abnormal ductus venosus Doppler. But one thing you have to remember, that near the, because ductus venosus is a very short conduit of vessel. So near that there is IVC which has a similar vessel. So sometimes you may get a reversal like thing, but that is actually not reversal. So you have to make it sure that those amp patterns should come to the baseline, and then it should reverse down. If it has not come down, if the diastole has not come to the basal line and
Yes.
it has reversal, that means there is some contamination of nearby vessel. So you have to be very sure this is ductus venosus reversal and it is not contamination.
Thank you, ma'am.
I have a question here related to the one which has been asked now. Is supposing the ductus venosus shows some abnormality. I think Aurobindo Naik asked this question, isn't it? Okay.
Yes.
So,
Yes.
so along with that, if the IVC, which is normally without any waves, which is a simple, if it shows any waves, this also means hypoxia, isn't it, Preeti madam?
No, madam.
It should not have any waves. The venous flow does not have any waves if it is normal. But if there is restricted flow or hypoxia, they start showing waves.
Yes, madam. Sinusoidal pattern like waves.
That is correct.
You can also have a look at that.
Yes,
and then again.
Actually, madam, when we are seeing for the IVC sinusoidal pattern wave, that time baby has almost gone. If you take out those babies also, those babies are not going to do it. They will have birth
extremely
asphyxia.
Important. So extremely important that if the A wave has touched the baseline, deliver the fetus forthwith.
Yes,
if it goes below, that means reversal means the fetus is acidotic. Even if it is live, you bring it out, it will either die or it will face a lot of sequelae later on, HIE and other things. Even touching the baseline, long-term effect on this fetus is also very bad. They will develop hypertension later on in life. They will have growth impairment, neurological impairment, so many other long-term effects on these babies. So you must be absolutely vigilant in taking the baby out at the right time. And when you take this baby out, you must do so in a facility where there is an SNCU and there are good pediatricians, neonatologists to deal with these babies. I hope we've driven the point home.
Yes.
Therefore, from all the guidelines, those IVC, renal artery Doppler has been taken out. Now only umbilical, MCA and DV. There is any abnormality, you have to deliver the baby. Don't wait till IVC goes down. That time your baby is already acidotic. You cannot even revive the baby. So don't go till that. You monitor the baby with the maternal uterine and these three vessels. Because you have to take a decision based on these Doppler only. Because beyond it, if the baby goes, baby is already acidotic, we have lost the baby. So don't go beyond this.
Okay, any more questions in the chat box or straight? You can unmute and ask. It is an extremely important topic. Yes, Sanjay?
Madam, brain sparing effect.
What is brain sparing effect? When the MCA has a very high systolic flow and very low diastolic flow. So, suppose now the baby is 32 weeks. So, the baby's systole is almost less than the double. Suppose 34 weeks means it should be less than 68. If it is more than 68, then we suspect anemia. High systolic flow will lead to anemia. High diastolic flow, you suspect hypoxia. So this is a formula you need to know. High systolic flow leads to fetal anemia and high diastolic flow. If the diastole is high in MCA, then you suspect hypoxia. So this is only the brain sparing effect. When there is a high diastole, your PI will come down and the baby will have hypoxia, that is known as brain sparing effect.
The cerebroplacental ratio, a little more clarification on that ratio, please.
What happens that whenever there is hypoxia, baby tries to give more blood to the brain and the vital organs like adrenals and heart and brain. So what happened? They spare the brain and there is increased diastolic flow. So they have named it as brain sparing effect. And ultimately how we will calculate? we will calculate it with CPR, that is cerebro-placental ratio. Cerebro means MCA PI, placental means umbilical PI. If we take the ratio of MCA PI by umbilical PI, we will get the cerebro-placental ratio.
Yes, there's another question in chat box by Norottam. He says that in some cases of preterm IUGR, we suspect, but mother can't be counseled for early delivery. So it is your counseling skill, and you have to see other parameters also, all the other flows also, DV flow, and then tell the mother and the birth companion that if they don't agree to delivering their fetus, it will be a jeopardized fetus. It will either not be able to live, or even if it lives, there will be permanent brain damage and permanent problems coming on in childhood and later life, adulthood. This you have to explain to them perfectly. Whenever you are doing in the ultrasound, you have to keep on talking. You have to keep on talking. You have to tell what is happening. You have to explain and show the images to the patient and the birth companion. Of course, for PCP-NDT, we don't allow. But in any case, you have to explain every bit of what you are seeing in terms of local terms regarding the health of the fetus. Preeti, madam, please elaborate on this question, the answer to this question.
How can we know the RI and PI are either normal or abnormal? Yeah, actually you have to follow chart. There are books where charts are being given, or you can directly go to FMF calculator, perinatology calculator. There are so many calculators available online. You can directly put, they will ask for the gestational age, and then you have to put the PI value. Remember, RI has no role in present day obstetrics. So forget about RI. Even though values are there in those calculator also, you just go to www.perinatology.com or fetalmedicinefoundation.com. You will get the calculator, obstetric calculator. In those, they will ask for the gestational age and the PI value. If you put it, they will tell you that at what percentile it is coming. If it is anything which is more than 90 percentile, it is abnormal. So on a rough, at 32 to 36 weeks, usually umbilical artery PI varies up to 1.2, 0.8 to 1.2. Anything between 0.2 to 1.2 is normal. 0.8 to 1.2 for umbilical. For MCA, anything which is 1.5 to 2.3, 2.4 is normal. So you can always find out. If you are not getting, you can call me at any time. I will guide you how to get it. But it is easy. You just put www.perinatology.com and you ask for a calculator for PI, you will get it.
Great.
Please, one presentation about Doppler USG in one day. That only,
See,
madam.
Doppler is coming almost at every presentation, especially on Doppler. There was one presentation by Josna madam, and don't worry, we are Preeti madam and all the trainers are coming down to your district to show you on the machine actually all the Dopplers, how the settings and everything. So till then you take the help of any experienced sonologist nearby or your application engineer. Ask the application engineer to show you the Dopplers and the interpretations, and you read the ebook, read what the practice guidelines which have been supplied by your emails by Hashmukh sir. Those you keep be ready, and also the PowerPoint presentations that have been given to you after every session. So have a look at those also, and please wait until the trainers who have agreed for on-site mentoring, they will come up to you and they will help you also.
And the next question is, how can we differentiate SFG, that is small for dates, with symmetrical IUGR? So symmetrical IUGR, asymmetrical IUGR, those terms has been gone. Now they have put now we can put it as early FGR and late FGR. So there is no term now like selective IUGR. It is all about early and late FGR that I have already told. Small for gestational age SGA fetuses, that is SGA fetuses, they are the fetuses which with birth weight between 3rd centile to 10th centile without any Doppler involvement. SGA fetus, I repeat, SGA fetuses are the fetuses which are between 3rd to 10th centile without any Doppler involvement, whereas the FGR fetuses are the fetuses which have birth weight less than 3rd centile even though the Doppler is normal, or between anything which is less than 10th centile with Doppler involvement. I think it is clear, Kishore sir.
So, Kishore Mahapatra? Kishore Chandra Mahapatra? Yes, there is one Kishore. Quite junior.
Yes, ma'am. Good afternoon, ma'am.
Kishore, welcome. It's a very valid question, and so you should give off whatever is now extinct, sorry, sort of outdated. Symmetrical, asymmetrical is not important. You have to remember what Preeti madam said. Growth restriction with normal Doppler, growth restriction with abnormal Doppler. Okay. So that is most important. Abnormal Doppler means you have to be like a hound and see that it doesn't go beyond the levels where the fetus is totally jeopardized. So in that case, you have to be ready for termination, ready with counseling, ready to transfer this patient in utero, if possible, to wherever there is a good SNCU, and it will be cesarean section and cesarean section and cesarean section alone for these babies. You cannot allow these babies the anoxia of labor. So don't terminate them, and you have to do proper counseling to the patient, and always have birth companions right from the antenatal OPD. They are a great help in taking decision making for the patient and in explaining to the patient. Okay. So abnormal Doppler growth restriction with abnormal Doppler, growth restriction with normal Doppler. As long as Doppler is normal, you can continue. Okay. But when the Doppler is showing changes, then you have to take rapid decisions, counseling, do the termination. If in your place you have a good SNCU, you do the cesarean section and let the neonatologist be by the bed by your in the OT, so that and your nurse SNCU sister in the OT, and carry them warm, and in your if you have transport ventilators or transport incubators, you put them in there and take them to the SNCU. In that case, you will do the best for the baby. Otherwise, we will have long-term sequelae, and these babies will be have poor growth later on, poor mental functions later on, all sorts of problems. So it is our quick decision, quick alert, like a hawk, like an eagle. You have to look at these Doppler studies, and as soon as you find them, and remember that these growth restricted babies, you are not going to see them only 4 times, just like any other patient. You have to call them down frequently. Preeti madam has said even maybe sometimes every weekly you may have to call them. If you think that the umbilical artery is showing problems, or if everything is going on okay, you can see them every bi-weekly also. And when there is a trouble, you may call them even for after a few hours, or 48 hours or 24 hours. So all these things are extremely important for maintaining the quality of that fetus, which the mother has been carrying on with so much of her time. It's a very valuable baby. All babies are valuable, but these are the babies where you can save from harm by taking timely decision. Any other questions?
Ma'am, CPR 1 is our cutoff for ये माने anoxia ये माने babies. But how much low we can go?
No,
Because
no,
I
no.
get even 0.9 more
CPR1
than
is
so many
not
times.
always normal. You have to go through the chart only. CPR1 was long back, it was taken as normal, but nowadays we don't take CPR1 as normal. Even for 28, 30 weeks, CPR 1.2, 1.3 is also abnormal. So these CPR are gestational age dependent. Previously we used to take as 1, below 1 is always bad, but even though above 1 is also bad, it is gestational age dependent. So please put them in values, put the gestational age and then calculate the CPR, and you see at how much percentile it is coming. If it is more than 90 percentile, that is abnormal for that period of gestation. Please don't go by that rule. That rule has been obsolete since long.
I have a question. If we are suspecting that the fetus is going to be jeopardized, can we do a biophysical score and see the breathing movements, the tone, and fetal heart pickup after a stimulation? All these things can also help us to take an early decision, isn't it? Can you give some light on that?
No role. Previously, they had a role because the Dopplers were not so advanced, but because of the onset of Doppler, it helps us in early picking up of high risk obstetric cases. So we need not do all these BPP and all, they are all obsolete now. Now nobody is practicing because for doing a BPP, at least you need half an hour for fetal breathing movement and fetal body movement. So in that, in quite less time, you can decide by seeing the Doppler itself. So there is no use of that. It has been completely obsolete from the international guidelines. At present day, no role of BPP, no role of anything. Doppler is the most important tool in picking up those babies who are going for to jeopardize and who are doing well.
And what about the maternal input of reduced fetal movement? Because mother is the best monitor, isn't it? So if the mother says fetus is not moving,
definitely, if the mother is not feeling fetal movement, there is a baby who is compromised. Because as you have already told, that mother is the best person who can tell about fetal movement. But sometimes what happens, if the mothers are busy, they really don't monitor the fetuses, and they are at the end of the day they are apprehensive that I could not perceive. So we have to be very sure whether they are perceiving or not. We need to see immediately those fetuses. We need to do the Doppler. We need to see the baby. And if you find in the scan that fetal movements are okay and Doppler are okay, then we need to counsel the patient. Your baby is doing fine. I have lot of such patient as referral. That patient is not perceiving fetal movement on daily basis. So I ask them that after taking your lunch, breakfast and dinner, just turn yourself in the left lateral position in 1 hour. You count the movement and then you let me know if you are perceiving or not. Usually after the food, the baby used to move the maximum because the baby becomes hyperglycemic and baby wants to jump around. So I asked them that please after breakfast, after dinner and after lunch, you lie on the left lateral position, and for these 3 hours you just calculate whether you are perceiving the fetal movements or not.
Exactly. So it's an important message to all of you that you should never assess any Doppler or fetal health before without in empty the mother having in empty stomach. She should be well fed, and if she has not taken her lunch or breakfast, she should take a lot of glucose drinks before you do the ultrasound scan.
Yeah.
There's another question by Narottam. Somebody had a term IUD. I'm sure the Doppler studies were not done in this case. If they had been done, this IUD could have been prevented. What do you say, Preeti madam? Look at that question. Look at that question.
Most common cause of term IUD are late onset FGR, where the babies are appropriate for gestational age. That's what I'm telling. In 2017, there was a paper and they could find that 80% of the stillbirth, the causes are late FGR. Previously, we had no terms of late FGR. Because of this paper in 2017, everybody got to raise their horns and they obsolete the term symmetrical and asymmetrical IUGR and they put the term as early onset and late onset FGR. I told you that late onset FGR are the FGR which present with term IUD and stillbirth. So you need to be very cautious because all these babies are almost AGA. They are appropriate for gestational age. The only problem is there is brain sparing effect and there is altered CP ratio. So you have to do routinely all the patient one scan at 28 to 30 weeks and the other scan to 34 to 36 weeks for fetal Doppler to catch late onset FGR fetuses.
Very important message. Hope everybody has noted what Preeti Madam has said. This message, and thank you very much.
Umbilical artery or other artery to be done.
कौन नरोत्तम कहलो?
Doppler माने umbilical लो खाली करा हबो ना सब Ductus Venouser जोड़ा भी
नहीं, Doppler of umbilical, MCA and DV. These three vessel you have to do because अपन जदि umbilical and MCA करिबे then only अपन CPR टा काढी परिबे ना, otherwise how you can calculate CPR is
करा हो जे
MCA PI divided by umbilical PI is CPR. So you have to at least minimum these two vessels you have to see, umbilical and MCA.
Yes, ma'am.
Okay, Sambit, shall we start the post-poll questions?
Yeah.
And after the post-poll, don't leave, because each of the questions will be discussed by Preeti Madam. So all of you start attempting the post-poll questions after this talk. I'm sure all of you will definitely answer well. And please stay behind to know the right answers and why they are right. Preeti Madam will discuss at length all the questions. Okay, the post polls have started. Please don't leave. In your own interest. It is in your own interest that you should attempt the post poll questions and see how much your knowledge has increased. And of course, you should stay behind for each of the questions to be discussed by Preeti Madam. Don't leave. Start answering the post poll questions. Yes, very good. समस्ते पोस्ट पोल क्वेश्चन आंसर करंतु डरंतु नहीं आमे जानि परिबुनी आपण भूल कहउचंती कि ठीक कहउचंती आपण निजे ही जानि परिबे निजरो इंप्रूवमेंट ओके सो एते परिश्रम करके रहिले सुनिले you have to assess yourself. It is a very important tool. Post poll questions attend कले निजरो नॉलेज आहुरी बढ़िबो और कॉन्फिडेंस भी बढ़िबो यही छाड़ी के जानतु नहीं. Don't leave. Answer the questions and then listen to the answers by the expert. Please answer the questions and listen to the answers by the expert. Meanwhile, I have another question or a sort of situation. If it is both macrosomic baby, always try to do a cesarean section. Don't attempt vaginal delivery. If at all somebody you have missed out and there is a shoulder dystocia, okay, the best thing to meet a shoulder dystocia is symphysiotomy. So symphysiotomy in an outlandish area in the periphery where there is now no chance. It is a simple method to save this baby. Don't pull the baby. Don't cut the do funny kind of episiotomies, lateral episiotomies, and all those things. So dragging the baby down, macrobots and all those funny things. Simply do a symphysiotomy. Just put in a nail cap, push the urethra away and cut the symphysis pubes. And take 80-degree angle between the knees by a sling. Put a sling at the knees and do a symphysiotomy. One symphysiotomy has been done at Bolangir recently of an obstructed labor. Okay, obstructed labor will head there. But in shoulder dystocia, it is mandatory to do a symphysiotomy. And any one of you can do it. It is not a difficult procedure. Okay, because we talked of fetal growth problems, macrosomic excessive growth. This patient may be diabetic also. And in that case, don't forget symphysiotomy. It is very easy. It has been done at Bolangir recently. Okay. Come on. Poll questions. Start. All of you, please attempt the poll questions. Please attempt the poll questions. And stay on to know the right answers. Okay. जो मैंने आगुरु आसीथिले आगुरु पोल क्वेश्चन अटेम्प्ट करछन्ती सेमानकर निश्चय राइट आंसर अछि जो माने डेरी रे जॉइन कले प्रेजेंटेशन आरंभ होई गलानी जॉइन कले सेमाने होय तो मिस करथिले हला किंतु एते सुंदर प्रेजेंटेशन इति मैडम कर हला आई थिंक दोज हु वर देयर बिफोर have attempted the poll questions, pre-poll questions, they will definitely give the right answers. So all of you, even if you have joined late, please attempt the poll questions and know the right answers before you leave.
Hello, Preeti ma'am, achanti na?
हाँ achanti.
One more thing I wanted to know, as she told 68 was systolic, MCI systolic pressure, 68 is a cutoff for fetal anemia. Same thing.
Hello, again, madam, I told if the baby is to a 34 period of gestation, 34 weeks.
34.
So you have to double the gestational age. So it should be 68. So MCA PSV should be always less than 68. If it is more than the double, then for that period of gestation, baby is anemic. It is for the peripheral doctors who doesn't have internet or who doesn't have anything. It is just a gross estimation for fetal anemia.
Is there any cutoff for diastolic?
I'm sorry, it's Satyajit Panda.
Just like
Please
this for
mute yourself. I think your horn is very disturbing. Yes, madam.
Is there anything for diastolic? No, nothing like that, no?
Nothing like that. For systolic only, to calculate the fetal anemia, we know for RH negative mother, we have to look for if the mean systolic, the peak systolic velocity should be less than double the gestational age.
Double to yes. Thank you.
Thank you, ma'am.
Dr. Preeti.
Yes, sir.
34 weeks primary gravida, late onset FGR. Hello. Is it audible?
Ajit, speak a little louder.
Yes, sir.
34 weeks primary, late onset FGR.
Yes, sir.
Umbilical artery Doppler, reverse and diastolic flow.
Again.
Ductus venosus flow normal.
Again.
What is next?
Sir, as per truffle trial, I have told even if it is 30 to 32 weeks, if there is reverse diastolic flow, and at 32 to 34 weeks, if there is absent diastolic flow, and at 34 to 36 weeks, if there is high resistance flow in the umbilical artery, we need to immediately terminate the baby.
No, I'm asking what is the role of Dr. Venouser then?
No role. That's what in early FGR I have already explained. In early FGR, before 30 weeks, the role of ductus venosus come. After 30 to 32 weeks, the role of umbilical artery predominates the ductus venosus. We have to take a decision now. So the decision after 30 weeks has to be made by umbilical artery Doppler and not ductus venosus.
In this case, what is the role of CP ratio?
CP ratio's role is for late onset IUGR. Here
I'm telling in
already
this
it has
case.
gone to reversal of flow, means definitely the CPR ratio will come very less. As you have
Role-
told that umbilical has gone reversal, so definitely
Yeah.
the CPR will be very less only.
And then what is the role of aortic isthmus Doppler?
Those things same. Aortic isthmus Doppler, it is the last one to see. When the baby has acquired when the baby has become acidotic. So if you are seeing the aortic isthmus Doppler, that baby has already gone. Matlab that has already approached the acidotic level. So those things now in international guideline, they have deleted all those things. Aortic isthmus, renal artery Doppler, IVC Doppler. Previously we used to do all these things. But present day guidelines, they have obsolete all those things because we have to see for the brain function, neuroprotection, as well as for the baby's mortality and morbidity. So we have to balance between these two, and so that we need to see only these three Doppler. No more aortic isthmus, no more IVC, no more renal artery. You have to take the decision based on these three Dopplers only.
No, what I mean to say, madam, suppose in between 32 to 34 weeks,
Again,
and there is reversal of ADF in the umbilical artery,
again.
immediately we shall terminate or we'll give steroid and terminate.
We have to terminate. Yeah, you can give steroid. You can give steroid, and after 48 hours, you have to monitor the babies. You have to do the CTG, and then you can deliver the baby. It is always better to give the steroid and deliver because the lungs are not matured.
Because madam, one baby, we have lost one baby by waiting for steroid.
We
By
may
waiting
lose
for steroid,
again.
recently we have lost one baby. We have lost one baby.
There might be, sir, some very deep finding. So better you have to assess at that period of gestation. You have to assess, and if the baby has reversal of flow, better not to wait for steroid and better to deliver.
Yeah, that is the take home message to the hall. Because recently we have lost one baby by waiting for the steroid.
Yeah. We can wait because reversal of flow. Because now the guidelines are crystal clear. They have written that if the reversal of flow happens at 30 to 32 weeks, immediately deliver. But we as an obstetrician, we are having bit of we will give steroids so that lung protection will be there. But guidelines doesn't say all those things.
Yeah. Sorry, very clear. Okay, thank you.
Thank you, sir.
ଏତେ ଥର ଶୁଣା ଖୋଳୁଛନ୍ତି ହଁ ଆଚାର୍ଯ୍ୟ ତ ପଳେଇଗଲା ଆଉ ଏପଟକୁ ଏଇଟା
Satyajit Panda sir, please unmute, please mute yourself.
I can discuss the post-poll questionnaire, I think, ma'am.
Can we discuss,
Hello?
Dr. Sambit, can we discuss the post-poll questions? Can we have those post-poll questions, please?
Okay, shall we stop the post-poll?
Yes, madam.
Yes, ma'am. We should stop and start discussing.
Okay.
Okay, madam.
Stop the post-poll questions. 74% have attended. Now, Preeti Madam will discuss each of the questions and the answers. Okay. First question.
Ambit, can you share the screen, please? Questions, or should I say? First question is, how can you suspect or detect abnormal growth? Option A, by taking detailed maternal history. Option B, by measuring symphysiofundal height. Option C, ultrasound measurement of estimated fetal weight. Number option D, all of the above. So the answer will be all of the above, because by taking the maternal history, if the mother is having uncontrolled diabetes or hypertensive or any chronic renal disease, you know that there will be some discrepancy in the growth. By measuring the symphysiofundal height.
And in the history also, the menstrual history is important. The
Yes.
cycle pattern.
Yes.
Madam, share the screen, I think.
Yes, symphysiotomy, symphysiofundal height is extremely important. From this question, Preeti Madam has highlighted that you have to measure the symphysiofundal height. So all of them are important in order to detect. Okay.
So the answer is all of the above for question number 1.
Next
Madam,
question.
Madam, pre-orientation to post-orientation difference is from 88% to 94%. There is an increment.
88 to 94.
Okay, madam.
So good. Some people had some doubts, and 94% jump is good. Very good, encouraging thing. Next question, Preeti Madam. Second
question, define constitutionally small fetuses or SGA babies. SGA babies are the babies which are having the estimated fetal weight between 3 to 10 centile with normal Doppler. The first option is estimated fetal weight less than 10 centile with abnormal Doppler, that is FGR. And again the C option is estimated fetal weight less than 3rd centile with abnormal Doppler is also FGR, that is fetal growth restriction. So answer will be B. Constitutionally small fetuses or SGA babies are the babies which falls between 3rd to 10th centile with normal Doppler. Question number 3. What are risk factors for FGR?
Just wait, Preeti. Let us find out the pre and post pole difference from Sambit. In question number
Madam,
2.
pre and post difference is from 37% to 77%.
Oh, very good. So everybody has, those who have improved means who have been listening to Preeti Madam very with a lot of concentration and have gained that knowledge. Very good. I must give you a big clap.
Thank you,
to all the participants and also to Preeti Madam for clarity. Okay, next, third question. Question number 3.
Question number 3. Risk factors for FGR are circumvallate insertion of placenta. Number B, idiopathic. Number C, bleeding in pregnancy. Number D, all of the above. The most appropriate answer is idiopathic, because idiopathic is the most common cause of FGR. It is not circumvallate
insertion. We don't know the cause. Usually the cause is not known.
Yeah.
So what is the pre and post pole difference?
Madam, pre and post difference is from 2% to only 6%.
2% to
6%, madam. Madam, idiopathic. Yes, madam. Idiopathic is the right answer. So now the post orientation pole response, correct response is only 6%.
26 or 6?
Only 6.
Madam, 6%. Madam.
এটা বলতে বুঝি পারলেনি কে কি রে প্রীতি ম্যাডাম যেতବେଳେ কহিলে যে ইডিওপ্যাথিক মানে majority of growth restrictions the cause is not known. Patient is an doctor is an idiot and patient is pathetic. Okay, idiopathic. Patient is pathetic and doctor is an idiot. कौन गीतांजलि
ना idiopathic ता भी all of the above भीतर जाउ
सब स्पेशलिस्ट माने भी हे गले
मैडम idiopathic ता भी all of the above भीतर जाउ
Nay, all of the above have only because circumvallate insertion cannot cause IUGR. It is only velamentous insertion which is on the side of one side of the placenta that will lead to FGR, and bleeding in pregnancy will never cause FGR.
Okay.
Okay. Next question.
Next,
3, 4.
question number 4. Cerebroplacental ratio is important for diagnosing SGA, early FGR, late FGR, all the above. Is important for diagnosing only late FGR. SGA, there is no Doppler abnormality. In early FGR, there is all the 3 vessel will be abnormal. Both. And late FGR, the CPR is very important diagnostic tool in identifying, in diagnosing late FGR. So answer will be C.
Pre and post poll.
Again, madam, pre and post difference is madam 29% to improve 48%.
48.
Again, madam, 48%.
It's a good jump. It's a good jump, but because because we are discussing, because PT madam has discussed now again it becomes very clear. So all of you who really want to learn must wait till each of the questions are discussed. So now again she has reiterated why in late FGR the CP ratio will be important for diagnosing late FGR. So I think it is clear to everyone now. Now, if you answer this question, I think everybody will get 100%. No, 100% result will be there. Next question.
Question number 5. In truffle group finding, they for early FGR, lower brain impairment if delivery is based on. So it is actually the DV, ductus venosus, absent or reversed AV. It is actually very early FGR, less than 30 weeks. So less than 30 weeks we need to see for the ductus venosus only. If there is absent A wave or the reversal of A wave, we have to deliver the baby. But after 30 weeks only we have to see the umbilical artery. 30 to 32 weeks reversed umbilical artery, 32 to 34 weeks absent diastolic flow, and 34 to 36 weeks high resistance umbilical flow will tell you the answer. Because in the option there was no isolated umbilical artery and there is isolated DV absent or reversal of flow. So the answer will be C.
From pre and post difference is from 16% to 44%.
Again, it is a difficult question, but very well explained now by Preeti madam. So those who have waited for the right answer, you have done justice, and those who have correctly answered, you have understood well. Okay. So in our practice, I think we will do justice to the baby. Next question, Preeti madam.
Question number 6. For calculating the cerebroplacental ratio, what we have to take? MCA by UA what? Is it resistance index? Is it pulsatility index? Is it systolic by diastolic ratio or any of the above? The CPR is always PI, pulsatility index. So the answer will be B.
And the pre and post improvement is from 39% to 83%.
Good, very good. Big clap to participants and the trainer. Very good, very happy. So pulsatility index always very good. Next question.
Question number 7. Which of the following statements are true for late FGR? Always diagnosed after 32 weeks. Number B, easy to diagnose, difficult to treat. Number C, induction at 37 to 38 weeks reduces the adverse outcome. Number D, poor prognosis. The answer is option C, that is induction at 37 to 38 weeks reduces the adverse outcome. Because option 1 is not correct, because always
Okay,
diagnose after
Preeti madam,
32.
you're absolutely correct. What is the pre and post poll difference?
Madam, actually maximum participants pre and post orientation ne dita jagare A option को adhika response मिलची.
No. It is
Oh,
not always
in
diagnosed
pre-
after 32
you need to
weeks.
clarify, Preeti madam.
Yes, madam.
Again, this question you need to clarify once again.
There is we generally see it after 32 weeks, but it is strictly written there is no always diagnosed. It cannot be always diagnosed because there is a variability. You can get late onset FGR even at 32 weeks. So when there is a term called always diagnosed after 32 weeks, that is wrong.
আমার দুইটা পেশেন্ট জন্য শেয়ার পজিশন বুঝলো আমার দোকান
disturb karo na. Acha, my question to Preeti madam is, if there is a growth restriction, should one induce this case or should one go in for CTG and decide for elective cesarean section, because they may not be able to tolerate the hypoxia of labor?
No, madam. For late onset FGR, they always tell that induce the patient immediately. Induce the patient and deliver them.
So that means you have to give dexamethasone here, dexamethasone and induce.
No need, madam. We have
Because,
to induce at 37 to 38 weeks, na?
Just 39 weeks and less. The guideline is to give dexamethasone. So this is a question we will keep standby for Professor Khurana to answer in the next session, which will be on 8th. We'll ask this very question, keep in doc, because whether we can induce or whether we should give steroid or not between 37 to 38 weeks, and whether induction is okay, or should the patient, if it is a valuable pregnancy particularly, should be given an option for elective. After, of course, doing a CTG, if CTG shows non-reassuring pattern, then better to go in for cesarean section than induce. So this has two sides of the answer, and we will wait till Professor Khurana gives this answer. In fact, we'll ask on WhatsApp today. If whatever answer he gives, we can share it with you in the virtual group. The answer to this question which Preeti madam has, it's a very important question, and in fact all of us are in dilemma at this stage. So we'll ask Professor Khurana and Hashmukh sir, and we'll what is their opinion we can share with you in the virtual in your WhatsApp group. Next question.
Question number 8. Macrosomia is defined as estimated fetal weight more than 4 kg, gestational dependent weight more than 90 centile, estimated fetal weight more than 4.5 kg, any of the above. Answer is any of the above.
No, pre and post poll, Sambit?
Madam, pre and post difference is from 29% to 56%.
Good jump. Why was anybody confused? Actually, it is a confusing, deliberate confusion, because more than 4 kg for Indians, more than 4.5 kg for Americans. So those who have attended the lecture with a lot of attention should have post poll question correct. No, but anyway, there has been a jump, so it's encouraging.
Question number 9.
It's also now educative.
Madam,
Those who have
one
waited
doubt.
to listen to the answer.
No, late FGR definition to up to 32 weeks.
It is not always. There is a borderline at 32 weeks, but it is not always. It can present at 30 weeks also. So that you have to keep in your mind. For that only I have framed that question like this. Because there is
early
not
onset
any...
is before 30. Early onset means before 30.
Early onset is before 32 weeks, but early also they have in all international guidelines you will find that they have written there is overlapping between early and late IUGR. So there is not a fixed point that before 32 only early will happen or after 32 only late will happen. So they can happen at any time of gestation, but preferably they happen before 32 weeks is the early, and preferably after 32 is the late onset IUGR. But it has written always after 32 weeks. That cannot be the answer. When it is always, it cannot be the answer.
Okay, next question. 9. Question number 9.
Question number 9. Syndromes associated with macrosomia are all except. So I have told the 3 syndromes which are associated with macrosomia are Beckwith-Wiedemann syndrome, Simpson-Golabi-Bemel syndrome, and the Soto syndrome. And the odd one out is Gruber syndrome, that is Meckel-Gruber syndrome, option C, which is associated with occipital encephalocele, bilateral polycystic kidney, and polydactyly. That is only Meckel-Gruber syndrome we often see in practice. So,
Madam, pre and post difference is from 18% to 79%.
Very good. Very good. Everybody has followed? Good. Congratulations to the group as well as the trainer. Next.
question
Last
number
question.
10. The last question. Which of the following statements is true for monitoring in twins? Monitoring DCDA twin every 4 weekly from 14 weeks, monitoring DCDA twin every 2 weekly from 20 weeks, monitoring MCDA twin every 4 weekly from 14 weeks, and monitor MCDA twin every 2 weekly from 14 weeks. As I have already told, the answer will be D. Monitoring MCDA twin every 2 weekly from 14 weeks of pregnancy, and the other answer is monitoring DCDA twin every 4 weekly after 20 weeks of pregnancy. So second option is not there, so the option D will be correct.
So now everybody must be clear that once you see a monochorionic twin, you have to see them very closely every 2 weeks. प्रति 2 सप्ताह थरे डाकी देखेबे डाकी फॉलो करिया. So 2 weeks once you have detected these situation is rare, but once you have detected it, you must see every bi-week, isn't it, Preeti madam?
Yes.
So what is the pre and post pole jump?
Madam, pre and post jump is from 39% to 90%.
90%. Good. Fantastic. Oh, very good participants. Thank you very, very much. And something in the chat box is there? 34 last. Oh, Ajit sir's question.
Ajit sir has already asked, I think, the same question here.
No?
We have discussed, madam.
Thank you to everyone for your attention.
Madam,
Now,
I want to tell something, madam. Can I send a picture of a placenta in this group to get the opinion from you? Picture of the placenta delivered. Placenta delivered. I will send a picture in this group, WhatsApp group.
WhatsApp group you have posted?
Yes, no, I will, with your permission, I will send.
Oh, we have actually made it admin control. So I will, for your sake, I will allow for you
that
to
patient
post.
was having 2 IUD. And recently she delivered a baby with 1.4 kg and AFI6. So the placental picture.
The baby live? Is the baby live?
Baby is live till now.
In SNCU?
Yes.
Oh, very good. So you can you show the picture in your mobile?
मैडम आपण एबे स्क्रीन शेयर करी कि भी से पिक्चरटा देखै परिबे.
मते जणा नै मैडम.
नै नै तमे मोबाइल रे देखाओ. से मोबाइल रे फोटोटा अछि तो?
हाँ मोबाइल रे अछि
मोबाइल रे तमे जाइकिरी मोबाइल रे तमरो गैलरी को जाओ फोटोटा ये एनलार्ज करिकिरी देखाओ तमे जोडी देखुचो सेठी मोबाइलटा देखै दियो तमे जोटी तमरो वीडियोटा देखौचो से वीडियो रे तमे मोबाइल पिक्चरटा देखै दियो
आई एम ट्राइंग
मैडम तळे आपनकर लोअर पैनल ले शेयर स्क्रीन गोटे ऑप्शन थिबो से शेयर स्क्रीन ऑप्शन टा क्लिक करंतु तापर आपण गैलरी को जाय कि
सेटा अभ्यास नथिले करि परिबो नै से मोबाइल रे तमे गैलरी को जाई किरी तमे से फोटोटा एनलार्ज करो
मैडम
एनलार्ज करी किरी देखाओ तमरो से वीडियो रे जो तमे निज मुहटा जो देखा जाउची वीडियो रे सेठी तम मोबाइल टा आनी देखै दियो तमरो
मैडम सेटा हबनी मैडम सेमिति हेई परिबनी
अरे
मोबाइल रे बाहर कर देलो हो
मैडम मोबाइल बाहर के स्क्रीन शेयर करियो पड़ो अदरवाइज मैडम को फेस जेतु अपोजिट टू कैमरा अछि सेत पे दिसुची
अच्छा तो मैडम आई कैन सेंड टू योर पर्सनल व्हाट्सएप ग्रुप
हाँ दैट
अच्छा मु गोटे शेयर करछि देखो मु गोटे शेयर करूछि मो वीडियो रे तुम देखो एटा डायग्नोसिस करलो एटा होची लेट प्रेगनेंसी एटा होची एब्डोमिनल स्कैन एटा प्रीति मैडम से मु डिस्कस करिथिली मु आको भाबिली एटा बाउल ऑब्स्ट्रक्शन बोली किंतु एक्चुअली
I will send the photo of placenta after delivery
मोशन देखि परछो
हां मैडम देखि परछि
हां सेमिति मु कहूची तुम मोबाइल रे गैलरी रे जाइकिरी तमे तमने देखै देले एटा बाहरीबो जो चेटा चाहूचो देखियो फोटोटा उठैछ तो प्लेसेंटा रो से प्लेसेंटा फोटोटा एमति देखाओ
अच्छा अच्छा आई एम ट्राइंग मैडम
सो एटा मोर गोटे मिस्टेक हैतला मु प्रीति मैडम से डिस्कस करिछि एटा एक्चुअली मु लेट प्रेगनेंसी रे एमते पिक्चर देखा जायनी एक्चुअली एब्डोमेन रे किंतु तार जो देखा गला आउ जने फीटल मेडिसिन एक्सपर्ट को पचारली से कहले एटा बाउल ऑब्स्ट्रक्शन हबो किंतु एक्चुअली बाउल ऑब्स्ट्रक्शन
I got the picture but how can I send I do not know how can I show you
तुम मोबाइल रे देखौ छटी
हां
हो तमे पूरा मोबाइल रे जॉइन करछो मु मोबाइल रे काढी कि मो लैपटॉप रे देखैली तो एही परला
मैडम नले अपन कहा को भी पर्सनली से देखि देबो
That is what I am saying. She can send to someone. She can send on WhatsApp.
Yes.
गीतांजलि मैडम आपन पाके जहां रवि नंबर अछि ताको पठे
ना हो से WhatsApp ग्रुप रे देला मु ये कर दोची एडमिन कंट्रोल जो करथली ये कर दोची तो अलाउ कर दोची
Madam, I am sending from another mobile. I am
post करो मु दोउच रो जो एडमिन कंट्रोल जोटा थिला
Madam, I am showing the picture to you.
हां एबे पोस्ट करो से WhatsApp ग्रुप रे पोस्ट करो हां वेरी गुड अच्छा एटा प्लेसेंटा टा मल्टीपल फिब्रिनल डिजेनरेशन है पूरा हला तो कंप्लीट माने रिडक्शन ऑफ फीटल सप्लाई फ्रॉम द प्लेसेंटल बेड एटा जदी तमे 16 वीक्स पूर्वरु एस्पिरिन देछा तो होय तो एतेटा रेस्ट्रिक्शन है न थांदा हला जो चेंज हला लो कैपेसिटी हाई रेजिस्टेंस सिस्टम टा डेवलप कर जाई हला जो मल्टीपल जो एंडोथेलियल डैमेज है करी पूरा पूरी फिब्रिनल डिजेनरेशन है जाई छी
मल्टीपल नोड्यूल्स आर देयर व्हाइट नोड्यूल्स
एस्पिरिन देथिले एटा है न था आउ तार अप्लाटी करो एंटी फॉस्फोलिपिड एंटीबॉडी सिंड्रोम गोटे अछि सेटा करो सेटा आसी पारे हाई टाइटर एस्पिरिन सो नेक्स्ट प्रेगनेंसी रे बी केयरफुल टू do external artery pulsatility index at 13 weeks plus scan and then you can share it with any of us you can ring us ring Priti madam or Hashnuk sir or even Khurana sir you can give on WhatsApp next pregnancy hope we all pray for the baby to do well Gitanjali And thank you. You have saved the baby this time, and hopefully the later life quality of this baby remains good. Okay, thank you very, very much.
Thank
Any
you,
more
madam.
event?
Thank you,
Prithvi,
madam.
Excuse me, ma'am.
marvelous presentation. I
Ma'am,
myself
excuse me, ma'am.
Thank you so much, madam.
Very,
Hello.
very nice. Very nice.
Excuse me, ma'am.
Yes.
Yes.
Ma'am, namaste and good evening to all of you. Myself, Dr. P. Srilekha from SDH Panjanagar, Ganjam district. Today I have seen one case, ma'am. It is of G2A1. First pregnancy, abortion was held at 1.5 month gestational age, and now she is 11 weeks 4 days. Today she has done ultrasound. Amniotic fluid is scanty. It is written amniotic fluid is scanty. Previous ultrasound she did at 8 weeks gestational age. At that time, amniotic fluid was adequate, but now due to spotting, she had spotting 5 days before. I repeated the ultrasound. Now it is scanty amniotic fluid. How I will manage this case, ma'am?
Okay, so actually, amniotic fluid, when it comes, actually baby's kidneys start functioning only after 15 to 16 weeks. So whatever amniotic fluid we are seeing the baby's urine after 15 to 16 weeks. The early amniotic fluid shortage can be due to early amniotic fluid is due to secretion from the nearby vessels and the placenta. It is not due to renal function. So most probably the kidney is not a problem. Might be you just ask for the history of any coronavirus infection. Any viral infection can land up in less of the fluid, because in this corona times I have done 5 amnio infusions. Can you believe? Patient gives, all IVF patient gives history of corona last month, they land up with nil liker. I infused 5 amnio transfusion. Can you believe? In my entire 10 year, I have transfused these 5 amnio infusion only during this corona 2 year. And even last Friday, I have landed up one IVF pregnancy with very less liker at 19 weeks, and she had a history of corona 1 month back. So get the history of corona, nothing to be worried at 11 weeks. Follow up them at 15 to 16 weeks when the kidneys start functioning. See for the liker. If you still feel that kidney is okay and liker is not there, so we can do amnio infusion for her after checking if the karyotype is normal. So in those cases, you can see for a rule out chromosomal abnormality, and if everything is fine, we can go ahead with the amnio infusion. Usually one amnio infusion will do till delivery. So we can always have that options in mind.
Is also torch indicated in this case? Torch?
Usually, corona, I came across lot of
those
cases.
viruses also can cause havoc in the amniotic function.
But usually torch we don't get oligo like this, nil liker and all. But don't worry, even if it is less liker, don't worry. I think it will be normal when the kidneys start functioning between 14 to 16 weeks. So don't be apprehensive, or don't apprehend the patient. Just come and find, repeat the scan at 16 weeks, you will find normal liker. Still, if you have any doubt, you can always refer the patient for amnio infusion.
And human albumin infusion also has a big place. Human albumin infusion to the patient, especially when they are hypoproteinemic, hypoproteinemia is there. If you give human albumin infusion, then that also helps increase the liquor volume. It is the only infusion that will help, not hydration.
Does ma'am high protein diet can improve?
Yes, yes. Srilekha, you can ask the patient to have high protein, high protein liquid diet. Like ask them to drink milk twice, dal twice, all pulses. That will help her in gaining those fluids
I
back.
have advised her a high protein diet
Yeah,
and less.
yeah. I think
Okay.
high protein liquid diet. You ask
Have
them
you
to
done
take
a
liquid
Doppler?
more than solid because liquid is better absorbed than solid.
Shilita,
So you
have you
ask
done
them for a liquid
Doppler?
food.
Yes, ma'am. No, ma'am.
Doppler?
No, I have not. Yes, I am at
Indicates
Bhanjanagar,
good
ma'am.
14 weeks.
Now I
Better
am
to
at
do the
Bhanjanagar.
Doppler also.
You have to do
Okay,
the
ma'am. I will
USG
refer her. Refer her for your Doppler study.
For 16 weeks, you do the Doppler and aspirin may also help.
Yeah.
Aspirin I have given from starting, from first day of ANC. I have given because of bad obstetrics, means she had one abortion, previous spontaneous abortion. I have already advised from first day of the ANC.
She is now 11 to 13 weeks. Just do
those,
the uterine Dopplers and send the EFTS. Matlab see for the risk for preterm preeclampsia and all. And see the values of other thing also, whether the PAPA is low or high. Because low PAPA and high beta SCG also can cause FGR and oligohydramnios.
If she can afford, PLGF also can be done. If she can afford.
Okay.
And to all those who are still there, my question is, how many are you? How many are giving low dose aspirin, 150 milligram aspirin? And if so, have you faced any adverse effect on the patient? And when are you giving this aspirin? Is it not at bedtime? So if you give it at bedtime, as Preeti Madam said today, give it at bedtime, and please also tell us if there is an adverse reaction. Okay, because we are now going to improve our maternal and perinatal mortality. So maternal mortality due to hypertensive disorders, this is one molecule which can reduce it drastically. So everybody must pay attention on this uterine Doppler and before 16 weeks, and implementation of low dose aspirin at bedtime, 150 milligrams. And please, all of you, find out whether there is an adverse effect due to this. It is very, very rare. In my experience, I have not seen any adverse effect of aspirin at bedtime. I want you all to also observe your own patients and ask them if they have any adverse effect on it. Okay. So now shall we end?
Yes,
thank you very much. There's another
Thank you,
chat box.
ma'am. Thank you, ma'am.
Oh, thanks. Very
Thank
good.
you, madam. Thank you, ma'am.
Very and fruitful session we had, despite the absence of the giants. Of course, Preeti Madam is a giant herself. So I think Preeti Madam, we had a very useful and knowledgeable, knowledge improving session for myself and for all the participants. Thank you very, very much. Thank you Naveen, for your support in the pre-polls, post-polls, and
मैडम नेक्स्ट फ्राइडे उत्कल दिवस में गवर्नमेंट हॉलिडे अछि तो नेक्स्ट फ्राइडे सेशन ता हबो
नेक्स्ट फ्राइडे हबनी 8 तारिख हबो
आगे मैडम
कोन करी हमें एप्रिल परे पर तो हम ऑनसाइट मेंटरिंग हे जिवो तो 8 तारिख दिन होची नेक्स्ट सेशन
ओके मैडम
so we shall we in the meeting. Anybody wants their numbers to be uploaded in the ultrasound group, you can post it in the chat box for Sambit sir to include you. Any numbers you want included in the WhatsApp group, you can post your phone numbers so that Sambit will be able to include you.
Ma'am, can we include all the post-PG students of our college? Post-PG
Yes,
SR students.
Definitely.
And assistant professor?
Yes. They are all government employees and they need to improve their skills. Why haven't you shared all these with them? It is for them. Definitely. So please ask them to post their numbers here. Or
I'll post them. Thank you.
Number, so you can post it. Okay.
I'll do it, madam.
Almost number dio.
Hmm.
Because the government has wanted all government servants to participate, and not that because they are in a medical college they should not. It is very important for medical college faculty also to participate.
Thank you, madam.
Thank you, madam.
Very much. Shall we?
Madam,
end the
meeting end कर दो मुझे.
Yeah, thank you, Sambit, very
Thank
much.
you, Sambit.
And we will
Thanks,
discuss regarding the venue with Preeti madam this evening.
Yes,
Yes,
madam. I will discuss. Thank you so much,
Okay,
madam.
thank you
Thank you
very,
so
very
much.
much.
Thank you,
Thank you,
madam.
madam. Namaskar, madam.